we're talking about relationship factors, and I tried to come back to some of the factors that Professor Geraldi mentioned yesterday, and talking about what relationship impacts sexual function. And this may also relate to one of the questions that we had earlier concerning the role of a woman in the society and how this specific role may affect her sexual functioning. Then I'll quickly repeat some of the content concerning men's sexual dysfunctions. This is something that we already heard about yesterday, but I will talk a bit about how we can treat those dysfunctions with psychological approaches. And then the last piece will be some elements of sex therapy that we do in our practice and that can be applied to different sexual dysfunctions in women and also in men. We know that relationship duration, the longer you are with your husband, with your wife, with your partner, has a strong effect on sexual desire. And it's a bit unfortunate that this pattern over time is not the same for women and men on average. So we know that sexual activity and sexual satisfaction decline in women and men as the duration of the partnership increases, but sexual desire declines to a stronger degree, declines more in women as compared to men. And in contrast, the desire for tenderness, being close, cuddling, tends to decline in men and rises in women, on average. So it's not given that in every couple you see, in every patient you see, this is the pattern, but on average this is more common than the other way around. And one consequence that couples need to deal with is that one partner experiences more sexual desire than the other partner. I think Professor Geraldi yesterday said that about a third of couples have the same level of desire and all the other couples have some kind of different levels of desire, and they have to navigate this. And that leads us to the question of what we do with those couples and those discrepancies. I think one key point is that couples try to deal with those discrepancies on their own. They try to figure out strategies how to navigate those. And from my perspective, some of those strategies are good, and some are bad. I think one of the worst strategy you can try to use as a couple is force the other partner to have sex. And that's why I'd like to emphasize that sexual consent and really having consensual sexual activity that both partners want is crucial in marriage as well. And there may be couples where this isn't the case, and we need to be aware of this in our clinical practice, that there may be couples who, even if they maybe don't admit it, don't always have consensual sex in marriage, but that one partner puts pressure, psychological or even physical violence on the other partner to pursue their needs. And just neglecting that may cause problems when we try to find solutions for a couple if those aspects of violence are present in the couple. So we need to assess whether those strategies are good and are bad, and then work with those couples on good strategies on how to overcome sexual desire discrepancy. And there has been a position statement. I forgot to put the citation there, but you can find it pretty easily if you put the title in a search engine. And this position statement tells clinicians, physicians, what we can do to help couples who are experiencing those discrepancies. And the first step that we can do is normalize it. Don't say, oh my God, what you are experiencing is so abnormal, nobody is experiencing it. No, it's a very natural variation in sexual desire, and just telling couples about the course of desire over the long term of relationships can help them feel understood and not as if something is wrong with them. Then you can educate the patients, and you can try to promote open communication between partners. And at a later point in this lecture, I will give you some hints, some advice, how we can encourage open communication. we can then assist them in developing joint sexual scripts that are mutually satisfying. And that means that they can try to find out what kind of sexual activity is good for them, that both people are okay with, that both people consent to willingly, and maybe that both people enjoy. And that doesn't mean that both people always have to enjoy it to the same level. So, but it needs to be okay with both partners, how they approach sexual activity. Another thing is that in many couples, sexual issues aren't the only issues. So many have other areas of conflict as well, and sometimes it can help to really address those conflicts in other areas of life as well, because if you are just fighting over everything every day, maybe your interest in getting intimate with the person that annoyed you all day isn't as great. So resolving those issues is also important. And then stimulating self-differentiation and personal growth, really focusing on your own sexuality, how you accept your own body and feel confident in yourself, can also resolve the pressure of like only getting good feedback from a partner and only feeling confident when you are sexually active. A lack of sexual communication is associated with all kinds of sexual problems, and what I found when preparing this lecture is that the relationship between good communication and sexual function is stronger in married individuals and in collectivistic cultures. So in some very liberal, open countries, for example, and if you just met a person, it may not be as important to talk. But if you are married and you are together with a partner for several years and decades, you need to talk. It's not this initial spark that just makes it happen, like the passion overwhelm you both, but it's, if you are with someone for a long time, you need to talk. I guess in most cases there is no other way around it. So as clinicians, we should encourage open communication, but this open communication should focus on positive aspects, mostly. Of course, if there's a problem and you really don't like what your partner is doing, you need to find a way to communicate that as well. But the focus should be on positive aspects. What do you like about your partner? What do you like about what you do in bed? What are your wishes and your desires? And talking about those positive aspects may help you to find yourself closer to your partner again. And again, important for me to emphasize the need for sexual consent within marriage, outside marriage, everywhere. Now I'm just having a bit of background information, and it refers to one of the key factors we think about when trying to understand low desire from a psychological perspective. And one theory that I find pretty interesting is the so-called heteronormative theory of low sexual desire. For those who may not have heard this term, it's the idea that in many societies people think being heterosexual is good, normal, healthy, and men and women are just different. They are so different on a hormonal level, and there are so many things that separate men from women. And this also often includes that the role of the woman is caring, supporting their husband and families, and nurturing other people. And this heteronormativity, I won't really discuss if that's true or not true or so on, but many people believe it. And it finds different expressions within the relationship, and those are often associated with low desire. So we often have an unequal distribution of labor. Of course, men also work very long hours, but most commonly men are working for money outside the home to provide for the family, and a woman's job never ends. So she takes care of everything else, and she doesn't have to say, okay, I'm done for the day, but her work just continues taking care of the family, the kids, and so on. So it's unequal. I will not say one is more than the other, but it's unequal. It's not the same role. And often, I'm not sure if you have experienced this yourself, often women get into the mother role in a partnership. So they do things they do for their kids, but they also, of course, take care of their husband and prepare their meals and make their doctor's appointments and buy some gifts for the mother-in-law. So they really have a mother role in the partnership as well. Further, women are in many cultures seen as sexual objects. So they are something that we like to look at, they are beautiful, and often women put a lot of effort in their appearance to look good for men, for their partner in general, but they don't really see themselves as a sexual person, but rather as something that others admire and find beautiful and attractive and so on. And lastly, another thing that I'd like to point out are the gender norms about sexual initiative. Again, I'm assuming it may be the same in Asian cultures as it is in European cultures. It is somewhat expected for the man to initiate and take leadership in sexual activity. And so this leaves the woman kind of passive, and she may not be able to approach a partner if she wants to have sex, because it's improper. And all those factors could, in some cases, not all cases, but if this is like the role, I'm nurturing, I'm thinking about everyone else but myself, it really creates a distance between the woman and her own feelings of desire, because she feels this doesn't really matter in my day-to-day life. I'm here to take care of others, not to take care of me. And then having no desire doesn't really come as a surprise, I guess. Okay. Now we've talked a bit about relationship aspects and cultural aspects, and I'd like to talk about men's sexual dysfunctions and how they affect women, and what are some psychological approaches we can deal with those. So the sexual functioning of two partners is intertwined, and many heterosexual couples focus still their sexual activity on vaginal penetrative intercourse. This is like the main event of the sexual activity. Couples may do other things, foreplay, but this is like the main thing that they do. And this really puts a burden on the man's ability to perform and puts a lot of pressure on the man. And there are different typical clinical situations that I see. So for women with low desire concerns, it could be that maybe her partner in some cases experiences erectile dysfunction, and that leaves her feeling like, oh, I'm not desirable anymore, it's my fault, I'm doing something wrong, he doesn't find me attractive. And to really not feel those very negative feelings, she withdraws and tries to avoid some sexual situations. Or another typical clinical problem is that maybe her partner experiences early ejaculation, maybe, and the couple only focuses on penetrative intercourse and doesn't do much else. And in those situations, it could be that the couple doesn't really talk openly, and she is left sexually frustrated because she doesn't really get the time to get aroused or to get an orgasm. So that's not to say that this is the case in every patient we see, but it's common. So we need to think about men's sexual function as well when we're treating women. Again, here, those are the prevalence rates for the male sexual dysfunctions, and I also highlighted the numbers from Southeast Asia. So different sexual problems, lack of sexual interest, perceiving the sex as not pleasurable is something that's also very common in men. One of the forms that we already talked about in the very interesting talk yesterday with the many graphic pictures is early ejaculation, and that's characterized by an ejaculation that occurs prior to or within a very short duration of the initiation of vaginal penetration or other relevant sexual activities. And I think what I often show in my lectures is this interesting slide, because it differentiates something like from a very clinical perspective, the diagnosis that we give, from something that's more like non-clinical, subclinical. So we have those forms of early ejaculation. They have a very short ejaculation time, and this may be persistent or episodic, maybe psychological or genetic reasons, and those prevalence rates are not as high as one might think. So it's not that everyone is affected by those very severe types here on the left. But there are many men who are affected by this, what we call natural variation, who come relatively early, after a few minutes, and it doesn't really qualify for a sexual dysfunction, but they are not happy with it. They they feel insecure, they are not confident with themselves, and they may experience distress because they feel 3 minutes is not enough. And there's this last type that I call pseudo-early ejaculation. Those are men who have a relatively long time until they ejaculate, but they have the idea in their head, oh, it should be longer. I'm lasting 20 minutes, but maybe I've seen pornographic material, or I've heard other people say, oh, you should last even longer. And in those cases it isn't really early ejaculation because it's not early, but we need to talk with the men about what are the reasons why they think they should last even longer. So that's not a medical problem, it's a psychological problem. It's interesting to see, and I think most of you may already know this, that men of all age groups are affected. It's not something only young men experience, so the lifelong condition is something that's affecting young men, but it doesn't go away if the man gets older. And there may be a high comorbidity with other medical conditions, and I just put out this, this is an excerpt from the consensus paper. I think it's a bit dated, it's not the newest one, but the main part here is that for the lifelong condition, pharmacotherapy and those options are seen as the first line of treatment. And if you have a patient who has not a lifelong condition, who had control over his ejaculation, had longer times to ejaculate, and you do not have a medical condition that's just causing it, then you can try starting with behavioral therapy first. This is also something we covered yesterday, and I'm not the best expert talking about it, but there is some evidence that this medication can help some patients, and what I always try to come up with is giving you the summary of one of the largest trials that was done a few years ago. So in this randomized controlled study, patients at the beginning had an ejaculation time of about a minute, and then it increased to 3 minutes. But the placebo response also was 2 minutes. So that tells us something about the ways this treatment works, and some kind of psychological factor, placebo effect, may also work here. So I guess that leaves something open to really work with the patient with a psychological approach. And what we do here is we work with this graphic here, or some forms of this graphic, and it's from a book that I find pretty good, that was published in 2016, I guess. The reference is lost, but I can give you the reference if you're interested. It works with this scale here, where you can see this is the level of arousal here. 10 is like the maximum level of arousal, and 0 is no arousal at all. And at some point, if a man feels aroused, they get an erection here. This is this line here. And the interesting piece of this model is that it works with something we call danger zone. And this is a danger zone before the point of no return emerges, before there's like this physiological process that can't be stopped. And the man is going to ejaculate no matter what happens. So what we try to do with the man and the couple is that he really tries to get to know his own body, his responses, how he feels, and tries to identify his level of arousal to notice, it's getting close, we need to change something up, we need to stop the sexual activity, or we need to do something else, or we need to go slower, or we need to relax a little bit to let the arousal subside. And maybe this leads to a loss of erection as well, but that's no problem, as I will tell you in a few minutes. And then trying to prolong this time here in the medium arousal zone. So this is the rationale we have in trying to get like from this curve here to this curve that allows for a longer time of sexual interaction between partners. And I've put a lot of text in some of those slides that now come, because I think this text is something that you can really directly give your patient, hand out to your patient, or really go through with your patient together. So that's why I put all the text in there, so that you have all the information you need if you want to teach this with your patients. And the first thing that we try to work with our patients is trying to do something called the stop-start technique alone. And it is very simple. The patient masturbates on their own, and if he feels like, oh, my arousal is very high, he stops. And this way he tries to really get control back on the time until he ejaculates, and we encourage our patient to do this twice or thrice, 3 times, 4 times, about 10 to 15 minutes, and then they are allowed to stimulate themselves to orgasm. This is the first step. This is often not too difficult for the men, because they have a bit of more control over their ejaculation when they are masturbating, when they are alone. So the main piece of work is this, doing this as a couple. And the classical approach is that the partner, women or men, doesn't really matter, the partner takes over the stimulation of the penis, and the man signals when he reaches the danger zone. So he can say stop, or they can have a hand signal, or whatever they like. So the partner stimulates the penis until the arousal is very high, and then the patient notices it and says, okay, let's stop, wait a few minutes, and then resume the sexual activity. And once this works, they can try to get a step further and try to incorporate this technique into other sexual activity, other intercourse. Next step could be including lubricants that make the touch feel a bit more similar to what intercourse feels like, or they could include fantasies, so telling the patients, okay, while your partner is stimulating you, really try to think about having sex with your partner, and those things might make it more difficult for the patient to not ejaculate, and so those are the steps that we try to teach the couples. So we work with this curve, we encourage the men to observe their sexual arousal, we encourage communication again, and the man tries to identify the danger zone. There are variations, and we also try to encourage mindful body awareness. That's something that I would also talk about in a second. Let's jump to the second and last men's sexual dysfunction that I would like to quickly talk about today. Erectile dysfunction is characterized by the inability or marked reduction in the ability in men to attain or sustain an erection that is of sufficient duration or rigidity to allow for sexual activity, in most of the cases here, to allow for sexual intercourse. And the therapy rationale is almost the same. So it's again a stop and start technique, and the goal is for the men to experience that an erection can come, and an erection can go, and it can come back, and it is not a catastrophe. And it's not embarrassing if you lose your erection, it's not something to be avoided at all costs. But the partner and I were just accepting that sometimes there is no erection. And it sounds simple. For many men this is not easy to accept, but like those different steps, again, try to get the couple to learn to deal with a partner who is maybe losing an erection at some point during intercourse. Okay. You all know about the pharmacological treatment, so I won't go into that, but I will just quickly spend 1 minute or so talking about another thing that's not really a sexual dysfunction in the narrower sense, but that is something that we often see in clinical practice, and I feel that we see more commonly over the last few years, and that's something concerning the topic of sex addiction. And it really relates to the to the questions of how much sex is too much sex. One participant mentioned the woman who has 100 partners. Is this sex addiction? Maybe, maybe not. But there are very different cases that we can imagine where one could ask if it's too much. Maybe a young man masturbates 5 times a day and looks porn. Is this okay? Is this not okay? I guess that's something you need to discuss or find out, like, what your own opinion about that is. Other situation could be a man has frequent affairs and that's an STI and needs to get treated. Is this sex addiction or is this something else? Or a single woman who has no partner, has frequent changing sexual partners and maybe enjoys that. So I would argue that those things are not the same. It's not the same situation if someone masturbates all day or if someone has changing partners or affairs. And we need to be very careful not to labeling someone a sex addict if maybe that's a completely different situation and maybe it's completely okay for the person. So no one gets hurt, there is no distress, then I would argue that most of those things are okay. Many people do experience distress and feel bad for their sexual urges, and in those cases the ICD-11 has decided to frame this as a compulsive sexual behavior disorder, and this disorder can be diagnosed if there's a persistent pattern of failure to control intense repetitive sexual impulses, and this leads to repetitive sexual behavior. And it is really a diagnosis that can be found if the person reports that sexual activities is the central focus of their life and it leads to neglection in other areas of their life. They don't work anymore, they don't take care of their family, it is all about sex. And there have been numerous unsuccessful efforts to really reduce this, but they can't really help it. And another symptom of this could be that you do it despite adverse consequences, despite your partner threatening to leave you or leaving you, or if you don't really find it satisfying anymore. So many patients say something, okay, I masturbate all day, I don't really enjoy it, it's just like this urge I have, but I can't really help it. And importantly, this is also goes beyond things that are culturally sanctioned. So if we come back to the woman with the 100 partners, this doesn't qualify for this disorder right away, only because it's unusual. So you can have unusually high desire and not have this disorder. But in some patients there is distress associated with it. And I just quickly tell you about the approaches that we have. And I'd like to start with the last sentence here. There is a lack of research to date, so we don't really know which approach works best for those patients. The first approach is abstinence-focused, abstinence-based. So in those approaches, we tell the patients, okay, you try to completely abstain from the problem behavior, you do not masturbate at all, you watch no porn at all, and in some cases you don't have sex with anyone, you just let it be and don't do it. This is the first approach. And the second approach is a bit more nuanced, and there we try to encourage the patient to identify some, like, what are positive sexual outlets for you? What is good sexual activity for you? What feels good? What is healthy? And what are problem behaviors? And we try to navigate away and not forbid sexual activity overall, but try to find non-destructive positive ways with the patients. Both approaches include stimulus control, so we try to teach them how to avoid situations that lead to harmful behavior. One of the things that my patients commonly repeat is that they take their phone with them to the toilet and spend there some time, not only doing the other things in the bathroom, but masturbating to porn on the toilet. So one thing could be just trying to leave your phone on the kitchen table and not taking it with you. Okay, very quick overview. Let's talk about the sex therapy techniques. And I'd like to quickly point out some things related to sensate focus, but I guess we've heard, I think, the most crucial parts about this already, so I will focus on some other techniques that we have. Sensate focus was developed to help individuals and couples address sexual difficulties, and try to encourage them to focus on sensory experiences rather than performance or anxiety. And how I use it in my clinical practice is not only to really use it to resolve all sexual problems, but it's also an important diagnostic tool. Because if we tell couples to do sensate focus, and they come back to us and say, oh, it didn't work, my partner wouldn't do it, or he wanted to have intercourse after that, or oh, I was so tingly, I didn't want my partner touching me, then we have like more diagnostic information and we have new ideas how to help the couple. So it's both a treatment, but also a diagnostic tool as I use it. I always try to tell my couples to create privacy and comfort, and I acknowledge that it may be difficult depending on the living situation. We talked about the mother-in-law living in the same apartment, maybe not having a room for yourself. So you really have to find out what ways there are for your patients to get some private alone time. Then you should talk about communication, and you should talk about time commitment, because that's not something you can do in 5 minutes. So you need to have some time with your partner to really do those steps. The first step is non-genital touching, so there are different things you do first, like you get comfortable, and then one partner takes turn touching the other, and you focus on the sensation and how it feels and how you want to touch your partner, and not really trying to arouse them or anything. And if possible, the couple should reflect about their experience afterwards. If it's a really bad situation and the couple really don't know how to talk about it, this reflection could also be in the doctor's office or at the clinician's office in the next visit. So they maybe just write down a few things and you talk about it afterwards. The second thing it doesn't work anymore. The second step is to include genital touching, but again, no intercourse. That's something that was pointed out yesterday. You tell a couple no intercourse as part of those exercises, but you can just like include the breast in the same way you include the knee in your touching. Again, you switch roles and you try to reflect afterwards. Now would be a good time to And the last thing, I like the title, intercourse optional. So if the couple has proceeded, like finishing those steps and both feel comfortable and say, okay, yeah, it's good, it's a bit boring, you want to go a step further, then you can try to encourage them, okay, maybe intercourse is possible, but try not to focus too much on performance and orgasm and all those things, erection, but really try to see what comes up and be willing to experiment a bit. What I always try to include here is, in my clinical experience, people say, oh, that's interesting, and then next time you see that they didn't do it. And it's important not to scold them for that, and say, oh, you must do it, blah, 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 but really see this as an inspiration and try to find out what's going on. So maybe it's like the instructions that you gave are so confusing, so that's why I put the text here, so you can give them text back at home, because sometimes they say, oh yeah, I got it, and then they are at home, and it's difficult to explain to your partner, for example, what to do. And other things could be that there is a lack of partner cooperation or performance anxiety related to those exercises, and we as clinicians need to deal with those and maybe explore the reasons and encourage them to schedule those tasks and exercises, so we have a greater likelihood that they will do it in the future. The key points are here to communicate clearly and only the necessary information. Maybe the patients don't need all the background about those exercises, but just the simple exercises, and don't overwhelm them. because we are experts. For us it's quite easy, but they may not have heard of those exercises before. Keep it short in your instructions, emphasize the process, and use challenges that they experience as diagnostic information. And there is no perfect way to do it. Couples are different in their speed, so some take longer to accomplish those steps, and others are quite quick. Another thing that we do in clinical practice, and as I told you before, sexual communication is key. And one thing that I'd like to talk about with my patients is the different types of communication you can have about sex. So some things are best talked about at the kitchen table. So if you have a problem with certain things, then maybe it's best to talk about it in a neutral situation, where while you're walking somewhere or sitting there or watching TV or whatever, and not approach those topics when you're already naked in the bedroom. Because then people are often very vulnerable and they have different expectations, and you can't really discuss certain problems when you're already like in a sexual situation. Other options are you can talk about scheduling sexual activity, and then you can also make erotic contact. So if you think about something sexual with your partner, then maybe you can let them know in subtle ways that you're thinking about them in this way, and so try to create some kind of intimate atmosphere and tension between you. This is especially helpful if it's like a long-term relationship where couples don't really talk about those things anymore. Other things are that you can communicate during sex, of course, and I'd like to discuss with my patients the pros and cons of verbal versus non-verbal communication. I guess most of us know the non-verbal part, like moaning or like moving your body in certain positions, but that's sometimes not enough. So if we try to use only non-verbal communication to tell our partner that's good, that's not good, then maybe they don't really get what we are liking and not liking. So then it makes sense to tell our partner directly, oh, we like that, that's good, more of that, or let's do something else. And then there is this fifth category I call afterglow. So for some couples, it makes sense to really use this intimate, positive situation after sexual activity to really emphasize some things they liked. So it's not like you get an exam and you get like a grade, this was good, this was bad. No, that's not the way I would approach it, but really focus on positive things. What you enjoyed about your partner, what was good for you, so that you can create intimacy and closeness with your partner after you had sex. Okay, I'll jump to the next topic that is another area that's very important for psychological sex therapy, and it's something we call self-exploration and self-stimulation. And that's helpful for almost all sexual concerns, sexual dysfunctions in women, and you can put a different focus on it depending on what the sexual dysfunction is. It's a good start of a sex therapy, and it can be used to prepare someone for couples exercises. So maybe they are not open to work with their partner yet, but they would like to start alone by themselves. And for patients without a partner, that may be the most important component, because then you can't do sensate focus if there's no partner. For many women, especially those who have no experience with masturbation and don't know their body yet, this can be highly shameful. And they may try to avoid it. So we as clinicians may need to encourage them and tell them it is normal to touch your body. It's okay to touch your body. And it can help you, if you know your own responses, it can help you in your sexual life alone and with your partner. You usually start with mirror exercises, so those are more about self-exploration, they're not about stimulation yet. And then you encourage women to use a handheld mirror, for example, to really explore their genital area and look at what's down there. So, as compared to men, many women don't really know their genitals and don't look at them. So this can be an important first step to really try to find out what's going on there. And then in the next step, you can encourage women to combine this exercise with touch and let them explore feelings, sensations, behavior, and you can also use a full-scale mirror and let them look at themselves and their body and identify maybe some body image concerns that they have. This is something that's the first step of self-exploration. The next step is a self-stimulation exercise, and it's important not to only focus on the clitoris, but also on other parts of the body. And the idea is not to achieve an orgasm right away, but rather letting arousal come and go and discovering what works for the patient. For some patients, you might encourage them going slow and really focusing on the process and trying to relax, maybe if they are very tense. For other patients, it's more important to encourage them being curious and experiment and try something new, especially if they don't have any experiences with self-touch. If we have a patient who has difficulties becoming aroused or reaching an orgasm, those interventions might work as well. And I also try to use them. These are just like maybe some advanced sexual tools you can use, sex toys, but I always try to be like very cautious and not recommend some crazy stuff for patients, but for some women it may just be helpful using a lubricant, or I'm not sure if that's available here in Vietnam. In Germany we have like very small vibrators that are not like threatening like this, but they can be bought like in a drugstore or supermarket even. And those things might be a good start for some women just trying to use a vibrator to experience more intense stimulation. So this is just an example picture. That's not something that I would recommend to my patients, but there are like small things they can use if they want to explore as well. And also, I always like to include the following slide. It has a lot of text. You don't really need to read it. Those are like very specific exercises women with female orgasmic disorder can do. And I think it's quite interesting because some women are very ashamed and they don't really know, okay, what can I do? What are the things that I can do to touch myself? And for some women, not all, it is helpful to just give them a list and tell them, okay, you can circle your clitoris, you can use the fingers, you can use the palm, you can this. And for some, they check it on the list, and it helps them not being, that they don't need to be creative and come up with something on their own, but they can just, it has like something like official. My doctor can do this, and I'll do it. So for some patients, this is like a helpful approach, really having specific tasks to do. Okay. Another thing that I would like to mention briefly is that in the treatment of female sexual dysfunction, the concept of mindfulness has been newly discovered by Western medicine. And of course, I'd like to acknowledge it's not a Western concept at all. It's something that has been present in other cultures for a long, long time, and I think it's inappropriate really telling you something like I invented it or not. It's like a very traditional thing, but the way that it is applied to sexual dysfunctions is something relatively recent and new. And I find that the concept of mindfulness is especially helpful for women's sexual dysfunctions because it addresses two main problems that many women have. It teaches them to just accept some distressing thoughts and feelings they might have during sex, and to really focus their attention on the present moment. And that's something that many women struggle with, like being distracted, thinking about something else, worrying during sexual activity. And I think this concept really addresses those problems that many women experience. How do we use it in psychotherapy? We have like those very general exercises that we do for other mental disorders, such as depression as well. So we try to teach them how to smell something, taste something really mindfully. We have some breathing meditation exercises. And then in the next step, apologize, this is a picture of a man, but this is the one that I had in my presentation. I like to include a man showering in my presentations. So we try to move it to the sexual realm and teaching them to be mindful while showering, while applying cream, touching themselves, and then move into like trying to be mindful during sexual activity. And the key factor is trying to be present in the here and now and not judging themselves for their responses. And we find that this is very helpful for many, many of our patients experiencing low desire, but also experiencing pain during intercourse. Before I come to an end, I'd like to talk about something that I'm a cognitive behavioral therapist, something that we talk about as cognitions, thoughts, thinking patterns, and concerning sexuality, many of us, maybe all of us, believe in certain sexual myths that are somewhat cultural dependent and that we don't really explicitly know about. It's something that we have like an implicit knowledge of, that we are not necessarily aware of. But those myths can be something like you don't talk about sex, you just do it. Men want to have sex all the time. Sex has to be passionate, spontaneous, or also a man takes responsibility and leadership during sex. And those myths can limit a person's ability to experience sexual pleasure. And it's important that we don't use it to make our patients feel bad and say, oh, you believe this, but this is wrong. That's not the way we approach it, but rather we use it as a starting point, really thinking about our beliefs and trying to come up with more helpful, more positive beliefs. And that leads me to the last area of sex therapy that I want to talk about and that I find really crucial is trying to explore positive sexual resources. And ways we can do this is asking our patients, when was the last time you felt very desirable? What is special about your personal sexuality? Despite your problem, what is it that you like to give and share sexually with your partner? So really focusing on positive aspects of sexuality and making them not only focus on the problem and what is bad and what is dysfunctional, but what is positive and valuable about their own sexuality. And the reason for that is that not all sexual symptoms can be treated. It doesn't really matter if they're medical or psychological. We can't really help everyone. And so we need to focus on that sexuality involves more than just a problem, more than just a dysfunction, and that sexual relationships can be fulfilling despite having a sexual problem. And so this is why I think that exploring those positive aspects can reduce distress and help our patients cope with problems that they experience. Thank you so much.
Cảm ơn cô rất là nhiều về một bài rất là hay và thú vị. Em có 2 câu hỏi và em sẽ hỏi từng câu để cô có thể nghe. Đầu tiên với lại sunset focus, vậy thì chúng ta có một cái liệu trình cụ thể cho các cặp đôi trong việc thực hiện sunset focus không? Ví dụ một tuần bao nhiêu lần, một tháng bao nhiêu lần, và chúng ta sẽ kết thúc cái sunset focus này trong bao lâu khi mà họ cảm thấy họ đã có một cái mối quan hệ tình dục ổn định.
Thank you so much. I actually, I'm not sure why I didn't have a slide in my presentation, but it's a very important question. I'd like to tell my patients that they should try to do sensate focus exercises 2 to 3 times a week. So this is what I tell them. Many don't have the time to do it, but that's how I start. 2 to 3 times a week, and they need about 45 minutes for one session. So that's how I frame it and how I present it to the patients. And in my personal experience, thank you so much. In my personal experiences, many couples stay within the first steps of sensate focus, and then they either have the problem resolved or they stop doing it. So for me, I start with the first step, non-genital touching, and in some instances I always also allow them to maybe keep their underwear on. For some people it's difficult to be naked in front of their partner when they haven't been sexually active for a long time maybe, so they keep their underwear on, and in the next step try to do it naked, and then they incorporate some genital touching as well, and this really depends on the couple. And in many cases, the sexual problem, before we have like all the 3 or 4 steps of sensory focus done, it is in most cases, the earlier steps are the most effective. So just trying to be intimate without the pressure of needing to perform.
I just agree with you, but what I try to do with my patients is ask them, what is your goal? Because sometimes the goal is not to have intercourse, so we should be careful not to have that my goal as a therapist is that they need to have intercourse, but maybe they say we just want to be closer to each other, or we want to have more intimacy, and then after 3 times they come and say now we have more intimacy, so we're very happy. So I think, especially with, if women have pain or women have erectile dysfunction, sometimes we think the goal is intercourse, but maybe that's not the goal of the patient. So I think that's important also to navigate after that.
Thanks so much. I completely agree, and I think one question I get asked often is, how do you know when to proceed to the next step? When is the next step? When can the couple move from phase 1 to phase 2, for example? And I often say that when they find it boring, or okay, it's easy. So those exercises are not exciting in itself. It's not like passionate, and they are just like kind of boring and just okay, nice, relaxing. And if both partners feel okay, we've done enough of that, we can move on. We are curious, moving on, and that's a good time to move to the next step.
Câu hỏi tiếp theo là theo kinh nghiệm của cô cũng như là nước của các chuyên gia, thì việc self-exploration hay là self-stimulation thì chúng ta thực hiện ngay cả khi đối với những phụ nữ trẻ, hay đợi đến khi họ có một cái sexual dysfunction thì chúng ta mới hướng dẫn họ những điều này ạ?
There I have a very clear answer. I think I would encourage young women to explore their own bodies from an early age as soon as they're interested. So it's not something, if a woman is not interested and really doesn't really care, it's not that something that I would tell them they should do. But as soon as a woman is interested and asks, is it okay if I touch my body, if I explore my sexuality, I would say, okay, fine, go ahead, it's good. And it's one of the concerns that maybe in some conservative circles may be there, that if you allow women to touch themselves, they go crazy. But that's not the case. It's rather the case that if they know what they like and what their body needs, it's much more easy for them to communicate it to other people as well and feel confident and safe in their sexuality. Otherwise, they are lost if they don't know themselves. How can they tell someone else? And it's also easy to get exploited if you don't really know what your personal preferences are, what your boundaries are, what you like, what you don't like. It's much safer for women to really know their sexuality when they start being sexually active.
Dạ, một câu hỏi này là của bài trước. Sau một cái cú PTSD á, thì thường cái sexual dysfunction, một số người theo kinh nghiệm của em là thân chủ lại cái nhu cầu họ lại tăng lên, ham muốn tình dục của họ lại tăng lên với người partner của họ. Vậy thì chúng ta lại cứ đi điều trị về việc giảm ham muốn, giảm nhu cầu, giảm động lực tình dục. Nhưng rất là nhiều trường hợp sau một cái PTSD thì cái ham muốn và nhu cầu tình dục của họ tăng lên. Vậy thì như vậy thì chúng ta giải quyết cái PTSD hay chúng họ giảm cái ham muốn đó để phù hợp với lại partner của họ hơn ạ?
Thank you so much. That's a very important observation, one that I made in my patients as well. And I think many women with PTSD experience a numbing and a disconnection from their body, and for some people, being sexually active helps them actually regulate their emotions and feel their body. So I agree that in some cases this may be a way of them dealing with the PTSD symptoms. I would always emphasize the safety of the people and see whether it works for them or not. So if a woman maybe brings herself in very dangerous situations where she isn't safe, where she is maybe experiencing violence or so, I would work on that. If it's just like she wants to have sex with her partner 5 times a week, then I would work it the same way that we do with other couples with sexual desire discrepancy. I would just talk what works for this couple, what works for the man, the woman, and how do they navigate this. But trying to take this strategy from her and don't have sex anymore and trying to work on that doesn't really make sense until the PTSD symptoms are subsiding.
Dạ. Em có một câu hỏi về sense focus, đó là khi mà chúng ta thực hiện ấy, người thực hiện sense focus thì sẽ tập trung vào cảm nhận của mình hay tập trung vào cảm nhận của đối tác hay là cả hai?
Again, a wonderful question. Thank you so much. The goal for the active partner providing the strokes is focusing on what they would like to touch and their own sensations that they are feeling. So one of the goals of Sensate Focus is that each partner tries to tune into their own body and feel their own feelings and desires, because most of the times, or many times, our patients are more trying to please someone else and thinking about, is it okay for my partner and so on, and are really disconnected from their own feelings. So when you are touching your partner, you focus on your own sensations and your own wishes. And again, I think Maria told this yesterday, there is always a stop rule. So it's always clear that if one kind of touch is not okay for a partner, they can always say, oh, stop, please don't do that, it's tingly, it doesn't feel good. So there's always this rule that you have to be able to say stop to anything.
Yes. Thank you.
Thank you, Professor Velten, for my presentation. And I think we had 2 more questions today. So we don't have more time. Can we break now for 5 minutes for coffee? And after we have a special session with the moderation from Professor Anna with the case study. And after the case study, interview first. And the next session is moderation by Professor Anna and Linda for interview. Thank you very much. Now we had a coffee and 5 minutes, and we are back about 5 minutes for our session. Thank you very much.